And share screen. All right, so this going over some of the stuff from the respiratory system last class. So it says at sea level, the partial pressure of oxygen of the gas in the alveoli after inhalation is about what? Um, so this is important to, this is what's driving the movement of oxygen from the alveoli into the blood. And again, 75% of the people got it, 100. We talked about, the pressure of just the air is about 760 millimeters of mercury. The partial pressure of oxygen is going to be 21% of that, which is more like around 160 millimeters of mercury. And then by the time you get down into the alveoli and mixing the fresh with the stale air, you're down to about 100 millimeters of mercury. The blood returning from the tissues is down at around 40 millimeters of mercury, and that's what drives the movement of oxygen from the alveoli into the blood. Because the alveoli air is 100 and the blood is 40, and so the oxygen moves along its pressure gradient. This is going to be important if you got this wrong to kind of keep the order of things correct. It says, which best describes inspiration during pulmonary ventilation? And like I mentioned, it can be a little non-intuitive. Like the first thing that happens is, there's the chest volume increases because of the muscles, the diaphragm particularly, because of that section between the pleura that increases the volume of the lungs. And so that's the first thing. And when we're thinking about the lungs, the volume increases. That increased volume due to Boyle's law creates a low pressure. And then that low pressure compared to outside is going to cause air to flow in. So again, first the lung volume increases, then that is going to cause the pressure to go down due to Boyle's law, and then that pressure gradient is going to cause air to flow into the lungs. So make sure that that makes sense. And then breathing out, the exhalation, expiration is going to be the same basic idea in reverse. The muscles relax, the volume gets smaller. As the volume gets smaller, the pressure goes up. When the pressure is higher inside your lungs compared to the outside, now the pressure gradient is going to cause the air to flow out of you. So again, make sure that that kind of causality makes sense. What causes what? Volume changes, drive pressure differences, drive the movement of the air, which is again different than blowing up a balloon. Blowing up a balloon, the air going into the balloon increases the pressure, which then increases the size. So that's a very different, that's like this positive pressure as opposed to what's going on with your pulmonary ventilation. Oh, which muscle? Yeah, everybody got this. This is all the same answer. I just knew that some people would write diaphragm, some would write diaphragm, some people would misspell diaphragm, but this was good. Again, other muscles do help, particularly when you're doing like your forced breathing, like, then there's other muscles that are more, but in general, the majority of your ventilation is driven by the diaphragm. What nerve innervates the diaphragm?
Phrenic.
Phrenic.
Phrenic nerve, right? So that's like the only of the major nerves we actually looked at in this class. In anatomy, we go through a lot of classes, but in this class, I want to kind of re-emphasize phrenic nerve. It's critical to keep breathing, right? Your heart has its own intrinsic conduction system inside, right? If, again, I talked about like the zombie apocalypse, you pull the heart out of somebody's chest, the heart's going to just keep beating in your hand. But the lungs don't work like that. The lungs, the Main control, neural control is up in the pons in the medulla. And then that has to constantly send messages down the phrenic nerve, down to the diaphragm. And that constant innervation of the diaphragm keeps you breathing. If something damages that, like for instance, if you have a spinal cord injury above C3, and you're not going to get messages down the phrenic nerve, you're going to stop breathing and you're going to die. So it's important to remember diaphragm is the main thing driving breathing. Diaphragm is run by phrenic nerve coming out of, we talked about cervical nerves 3 through 5. That's why they say C3 through 5 keep you alive, right? If you get a spinal cord injury above there, you're no longer operating the diaphragm and you're no longer ventilating the lungs. Continuing. Large air passages such as the trachea, bronchi held patent or open by cartilage. Okay, everybody got that? Like I mentioned, when you get down into the really small little passages, the little bronchioles, then there's no more cartilage. Then it's just smooth muscle is enough. And then that smooth muscle is controlled by the autonomic nervous system, can increase or decrease the diameter. Name at least 3 different ways your respiratory system handles the dust you breathe in. So for this one, there's lots of different ways. When I was grading this, if somebody gave me, cilia and mucus as 2 different things, I didn't really count those as 2 different things because those are 2 different aspects of the same mechanism, right? The mucus kind of catches the dust and the cilia sweep it to the back of the throat. I wanted things that were different. There's like the nose hairs, the vibrissae, which is one thing, or the mucus and the cilia working together. I did, for this case, I gave people credit if they did coughing versus sneezing, even though I consider those kind of 2 aspects of the same thing, because they're both explosive air movements. One's going through the upper respiratory, one's going through the lower respiratory. There's also the alveolar macrophages, the dust cells moving around. So yeah, lots of different ways that your respiratory system tries to keep itself free of dust and all that. So let's stop sharing that. All right, so today we are doing the urinary system.
One quick question before we begin. This is all not going to be on the test. This is new stuff.
Correct. So the test will go up through everything from Tuesday, respiratory system. Everything we're going to do today is going to be on exam 4, which isn't going to come until actually after the last day of class. It's the exam we have during finals week. Kind of reiterate, exam 4, even though it's during finals week, is basically another unit exam. It's covering material from urinary system through the reproductive system, through the end of our class. In addition, during the finals week, there will be an optional comprehensive exam, which people can take if they want, that can replace a low score. It won't replace exam 4, but it will replace the score on exam 1, 2, or 3 if that ended up being particularly low. Again, the thinking that if you actually know the material by the end of the semester, that's what's really important. If you've done well on exams 1 through 3, then there's no reason to take it. It's just kind of a waste of your time. You should go just enjoy yourself. So it's important to use like the yellow for the urinary system. So as we start this one, we should talk about all of the functions that it does. And it's doing a lot of important things. What is the role of the urinary system in human physiology?
Filters the blood.
So filters, you know, filtration is part, I would say, I want something a little more specific.
Remove toxins or materials that we don't need.
Yeah, so one is, so let's say it removes wastes. So, when we say excrete, we mean actually leaves the body. So like, through peeing, so there's like nitrogenous wastes, like urea and creatinine, metabolic wastes, etc. There's all sorts of stuff that your body has to get rid of. And the urinary system is a way to actually get something out of your body that you don't want. What other things does the urinary system do?
Fluid balance.
It's a huge one. So water balance. By either keeping the water in your body or peeing it out, that's how you maintain your water balance, your osmolarity. And what is this also critical part of? We talked about
Blood pressure.
uh-huh. Right, so that water balance is a critical part of just maintaining the osmolarity of your body. It's critical for maintaining your resting blood pressure. So water balance. What other things does the urinary system do?
pH balance.
It's going to be critical for pH balance. We're going to talk kind of at the end of today about kind of the big picture of pH balance. The urinary system is the main kind of long-term control of pH balance. We've seen buffer systems that can react instantly. I talked about the respiratory system changing pH by having more or less CO2 in your body. Urinary system can literally pee out hydrogens or bicarbonates to do the main long-term control of your pH. So we're gonna, when we look at pH balance kind of as a whole in a little bit, we'll see the urinary system is a critical part of that. What other things does it do? Electrolyte balance. This is, sodium, potassium, etc. Right, we know that the amount of these electrolytes, these ions, is critical to this functioning, all the signaling in our body and all that. The urinary system are going to be the ones that are making sure that we have the right amount, maintaining the homeostasis of electrolytes. And actually, when I talking about, both of these are going to come up in our lab next week. I'm going to talk about kind of coming up with hypotheses for the next week's lab a little later, but just kind of a little spoiler alert. as part of your pH balance and electrolyte balance, your kidneys, your urinary system are going to have to decide what to keep in your body and what to let go of, right? So, the pH, is your urine acidic or basic? It really depends on what you've been eating and everything, and what does your kidney have to do in order to maintain pH balance. If you're a little too acidic, you might have to pee out more hydrogens, in which case your urine is going to be more acidic. A different kind of diet means you might actually be peeing out bicarbonates, in which case your urine might be alkaline. Same thing with electrolyte balance. You've just been gobbling salty pretzels, you might have really salty urine. Or maybe all you've been eating is carrot sticks and drinking tons of water. You might have, really, really dilute urine that's pretty much just like water, right? So your urinary system is going to either hold on to things or remove things from your body as appropriate to maintain pH balance, maintain electrolyte balance. What else do I want to say here? So there's a couple of other kind of things on the side.
Would it be, sorry,
Go ahead.
would it be okay to say it controls, autonomic controls nervous system by releasing epinephrine via the adrenal gland?
It doesn't do that. Yeah, so that would not be right. So what it does do, though, is help control blood pressure through the renin-angiotensin mechanism. So it releases renin. Which we talked about, starting that whole renin-angiotensin mechanism. And we'll talk about more in detail what part of the kidney is doing that and under what conditions that makes sense. This can be activated by the sympathetic nervous system. So the sympathetic nervous system can tweak this to cause the renin release, but it can also happen just due to the kidneys noticing blood pressure dropping. It releases erythropoietin. This is, I've mentioned, this is what increases red blood cell production. Again, sometimes people call it EPO, particularly if you're talking about it as a performance enhancing thing. This doesn't make, I'm not quite sure why the kidneys are in charge of this, but they are. So if your body needs to increase its ability to transport oxygen, the kidneys will release erythropoietin, which will tell the hematopoietic tissues to increase red blood cell production. Another thing the kidneys do activates vitamin D. Vitamin D, it gets its name from dermis of your skin. This is the one that gets created you need ultraviolet light. This is why you need to be out in the sun. If you don't have enough sun, you usually don't make enough vitamin D, but it's actually the kidneys are necessary for activating this. And vitamin D is necessary to absorb calcium. Right, that's, kids, right now, if you buy milk, it's always fortified with vitamins A and D. So it's not as common like it used to be. Like kids who weren't getting enough sunlight and therefore not making enough vitamin D, were not absorbing enough calcium, their bones got soft and they get rickets where their legs would bend under their own weight. They'd be bow-legged. right? I mean, that's one of those trippy things. Like you always think about orthopedics, right? What does an orthopedic surgeon do?
Put bones into position.
Yeah, exactly. These are the kind of the surgeons that are more like carpenters, like sawing and hammering and things. But ortho means straight. Pediatrics. This is kids, children. So this was like little kids who had rickets and their legs were bow-legged, and they'd have to like break them and reset them and straighten them. So that's kind of, if you ever wonder, like, why are orthopedic surgeons named after, straightening kids? It's because of, kids who didn't have enough vitamin D and the calcium wasn't absorbed and their legs were soft, leg bones got soft and bowed out. But back to the urinary system. Again, removing waste is just one little, it's not one little, but just one part. When you think about what the kidneys are doing, they're really important for water balance, pH balance, electrolyte balance. And again, our labs are going to kind of focus on that, really kind of hopefully get you thinking about that. Okay. Let's start with a little bit of just overview of kind of the anatomy of this. So then we can kind of start drilling down and see how does your urinary system do all this? So at the core, what are the main organs that are responsible for all the things we just talked about?
Kidneys.
Your kidneys. So these are, they're kind of like in your lower back. Maybe. So lumbar region, they're kind of lower back, retroperitoneal. They're behind the serous membrane that envelops all your digestive organs. About the size of a bar of soap. Shaped like a kidney bean or a kidney shaped pool. I think they get named after the kidneys. It is worth talking about the renal arteries entering in. Whoops. I don't know if anybody remembers when I'm talking about the proportion of blood of your cardiac output that goes to different parts of your body. Does anyone remember how much of your cardiac output goes to your kidneys?
Like 25%, 20 to 25.
Exactly. So 20 to 25% of cardiac output to the kidneys. So that's huge. So what is a resting cardiac output? Does anybody remember?
Was it 5 liters per minute?
About 5 liters per minute. So again, resting cardiac output is about 5 liters per minute. So that means somewhere between 1 to 1.25 liters per minute are heading into your kidneys. This is going to be important. We're going to follow this blood and see what happens to it as we get more into detail of the functioning of the kidneys. When we start talking about filtration and stuff, we're gonna follow this. So keep this in mind, because this we're gonna come back to. So there's obviously renal veins draining it, but you can just assume that the rest of the flow is there. Then the stuff that's going to eventually leave your body, be excreted, whether it is excess water or electrolytes or wastes, they're going to leave out these things called the ureters. That's too big. Hold on, let me make that a little less dramatic. So the ureters, whatever the kidneys are going to have to get rid of to do all their balancing act, is going to leave the kidneys via these things called the ureters. Obviously, it's very convenient to not just dribble out urine constantly as it's being produced. So we have this cool system to store it until we're ready to get rid of it. So that's going to be the urinary bladder. The urinary bladder is got a lot of smooth muscle in. Then there's an extra tube. We can make it a little longer here. Whoops. The part that leaves the bladder to the outside world, basically to pee, that is the urethra. So ureters go from the kidneys to the bladder. Urethra goes from the bladder to wherever you're peeing. The urethra will, it can be different length. If you are a woman, the urethra is only like 1.5 inches. It doesn't have to go very far. The urethral opening is just in the vulva. It's very close. In a guy, the urethra is a lot longer because it has to go down, goes through. When we get to the reproductive system, we'll talk a lot about the different parts of the male urethra, the membranous urethra, prostatic urethra, penile urethra. In general, because the female's urethra is much shorter, and also because the female urethra is, when the vulva is, there's going to be the urethral opening, the vaginal opening, the anus, they're all kind of in the same zone. It's more likely that there's bacteria or something that can make it up to the urethral opening. It's much more common for women to end up with urinary tract infections because this opening is not first it's close to where there's bacteria, and it's also not a long distance to get up into the urinary tract. Guys, it's much, much less common to have a urinary tract infection because there's a much longer urethra always kind of getting flushed out. So UTIs. The urethra has 2 different sphincters. We'll introduce them now. We'll get back to them as well when we get to the reproductive system. So there's going to be an internal sphincter, internal urethral sphincter, which is made out of smooth muscle, and an external, which is skeletal muscle. And these are going to be operated. One is autonomic. Obviously, the one that smooth muscle is autonomic. This one is part of a reflex that is triggered by stretch receptors in your urinary bladder. Right, the urinary bladder starts filling with urine. It can actually fill up to like a couple of 100 mils without even stretching. But as it keeps filling up, it will start stretching. Those stretch receptors send a message to your spinal cord. This is going to be a spinal reflex. And that's going to cause a relaxation of this internal sphincter. And when this internal sphincter relaxes, then you feel this pressure down a little lower. And that's like that urge to urinate. It's like, oh, I got to pee. But luckily, you've got the external sphincter, skeletal, voluntary. So you can choose, am I going to relax this one or not? Is this an appropriate time or place to actually let my flow begin here? If you keep holding it, this kind of, backs off, but then a little later it'll run again and you still get this feeling like, oh yeah, I gotta pee. So I think, and the bladder can hold, I think, up to about 1 liter or so. I think I have it here. Yeah, I have here, yeah, moderate lift. So it can get up to like about 1/3 of a liter without increasing too much pressure. 1/2 a liter, you're starting to really feel you got to go. It can fill up to about 1 liter, I think, maximum. And again, when we get to the male reproductive, these two sphincters are going to be important too, because this is the space in between is going to be where all the different parts of the semen are mixing together. The sperm and the seminal fluid and prostatic fluid all kind of mixed together like right before a guy ejaculates. So this will be a little more, this will be important. For a woman, it's just more about control of urination, but in the guy, it's also going to be important in how the whole kind of ejaculation thing goes on. So can talk very briefly about kidney stones, renal calculi. Right, calculus is because people used to use like abacuses, kind of little stones to do math. Renal calculi is also called kidney stones. Again, by definition. This happens when things precipitate in the urine. Like if you have very high levels of different minerals, or you can have, what kind of things can you get? You can get, calcium crystals, magnesium crystals, uric acid crystals. There's all sorts of different things that can start precipitating. And if that happens, think about if you've got like some kind of a super saturated solution of sugar and you start making rock candy in there. It's that same idea. If you've got these crystals starting to precipitate out of the liquid, they can get in here and start blocking the passage of the urine, which this is supposedly insanely painful when you have kidney stones. there's like a cool way, like when people do have kidney stones now, rather than cutting somebody open to get them out, there's this thing called shockwave lithotripsy. Litho is another thing for stone. Like a lithograph is like a big stone that you kind of use different stuff and then put ink on and stuff. Shockwave lithotripsy, they actually put you like in this bathtub and they focus sound waves that all focus in on the stones, shatter the stones, and then hopefully turn them to sand that then you can pee out. So it's a way of trying to get rid of the kidney stones without actually cutting you open, just by using these sound waves. That's why they call it shockwave lithotripsy. Using the sound waves to shatter the stones and making them into small enough things that will pee out, that you can pass. So, all right, so I think that's kind of the big picture. What we're gonna do now is actually a few more things we should mention, just for completeness here. Your kidneys are held in place, again, it's a little more anatomy. They're held in place by a lot of fat. There's this what's called the adipose capsule that kind of holds them in place. You know, if you've been in anatomy, when you kind of slice somebody open and you go under the peritoneum and you're looking, where's their kidney? It's like, I don't see it right away. It's like these big fatty pillows, and you slice open the little fatty pillow and there's the kidney sitting inside. The reason why I am mentioning this is like, this can be another clinical thing that happens, is like somebody who is like anorexic, for instance, and losing way too much of their adipose, becoming way too skinny. You can actually have the whole kidney kind of drop. You know, the idea for drooping is, or the word for drooping is ptosis. I mean, your eyelid can have ptosis if something's wrong and it droops weird. But if the whole kidney drops because the fat is not adequate, you can kink off the ureter, which can be a problem as well. So that's worth thinking about. Other thing, I'll just mention this briefly. Some people just congenitally have, instead of two separate kidneys, have one. They call it a horseshoe kidney, where it never separated into actually two. It just ends up being one big thing, which normally you have two kidneys, and each kidney alone actually has the capacity to do everything that you need to do to keep all that balance that we've been talking about. So we've been mentioning all of this stuff here. Normally, one kidney can do this. You know, I should say one healthy kidney, which is why it is possible to donate your kidney to somebody, because one kidney will still be able to continue doing this stuff. What if both of your kidneys are not working well? What do you need to do?
Dialysis?
There's dialysis. So I'll talk about that a little later, but you know, dialysis is basically, you know, artificial kidney. It's where you actually are taking, you know, taking the blood here, but instead of sending it to the kidneys, you're sending it out to a big machine that is doing those different things we were talking about. Or there's also continuous ambulatory peritoneal dialysis, which we'll talk about as well, where you don't use a machine. Instead, you use a dialyzing fluid just in your peritoneum. But yeah, if your kidneys are not functioning well, you need something else to keep the toxins from building up, to maintain your water and electrolyte balance and everything, or else you're not going to live very long. So what we're going to do now is look at the kidneys and figure out what's going on in the kidneys. So probably makes sense here to look at some pictures from our textbook, because it'll give you a good overview. I will upload these onto the Canvas, so you'll have them. All right, so this is just kind of showing what I've been talking about. You've got the kidneys here, here's the bladder, sitting here kind of in your abdominal cavity, again, around the lower back. Here is a kidney. And pointer options, I'm going to use the pen. I'm going to use, let's use that purple. All right, so here, all inside here, there are all these little structures called the nephrons. There's like these things called nephrons. There's like 1 million nephrons, these little repeatable units, kind of the same way we saw in skeletal muscle. The sarcomere was the structural and functional unit of skeletal muscle. The nephron is going to be the little structural and functional unit of the kidneys. The thing that, if we understand a nephron, we'll pretty much understand the basic of how a kidney works. So we're going to spend a lot of time talking about the nephrons. You know, at the end, all the nephrons are going to be making the urine, and the urine is ultimately going to be coming out the ureter. But the nephrons are the things that are in between, the things that take the blood coming in the renal artery and ultimately producing the urine coming out of the ureter. This renal artery coming in is just going to branch and branch and branch and branch into 1 million little afferent arterioles that are feeding the 1 million little nephrons. So when we look at the nephron, each nephron is going to be fed by a tiny little branch that originated from this renal artery. And again, ultimately, by the end of all of the processing of the nephron, whatever's left over is going to be the urine that leaves. Again, this is kind of showing more detail of a nephron. The nephron has the afferent arteriole coming in and ultimately urine leaving. We're going to look at this in a lot of detail. You can see from this picture, it's really twisted up. In fact, the names of the different sections are called like the proximal convoluted tubule and distal convoluted tubule and loop of Henle. And we are going to go into each of those. But before we go into the convoluted and loopy kind of detail, we are going to talk about the big picture of what are the processes are happening, so we kind of have an idea before we get confused in the details. So let's, so this, I'm gonna draw this out. We're gonna look at this, but I'll draw it a little more in real time here. So the basic structural and functional unit of the kidney is the nephron. Let's make it a little smaller. So the nephron. So what we're going to do is talk about nephron. First, we're going to kind of talk about overview of what is the nephron doing in overview. Like I said, an actual nephron is all twisted up and convoluted and loopy, but we're going to look at it first on a more schematic. So it's going to be fed by this little afferent arteriole. Again, this is basically the blood that is coming in. This is a tiny little branch off of that renal artery, right? I said it branches into like a million little afferent arterioles feeding each of the million nephrons. This is then going to go into a super leaky capillary called the glomerulus. Glomerulus means little ball. These are fenestrated capillaries, which we talked about being like super leaky. Let me. All right, so the part that's leaving here, this is called the efferent arteriole, actually. This thing here, glomerulus. Wait, let me spell it correctly. I think that is. Glomerulus, this is basically fenestrated capillaries. In a little ball. What do we know about fenestrated capillaries?
Let the things in and out.
Yeah, they're super leaky. The pressure coming in here is actually, it's one of the highest pressures going into, capillary beds. Usually the pressure is pretty low by the time you're entering into a capillary bed. When you're entering into the glomerulus, you're usually, it's somewhere around 55 millimeters of mercury, which is pretty darn high for a capillary bed. And there's a lot of leakage coming out of here. So what's happening here in the glomerulus is going to be what's called, this is going to be the first part of the process of a nephron. This is called filtration. So we lose water and also small solutes. So big things like plasma proteins and cells, they don't go out. But little things, anything less than like 3 microns gets to leave. Things up to about, things bigger than 7 to 9 microns get trapped, stay in the bloodstream. But small solutes, things like, urea, salts. But also, things like glucose. So the thing I want to kind of make clear here is the thing that's leaving is water, which we might or might not want to keep. Solutes, some things like urea, we definitely want to get rid of. Salts, we might or might not want to get rid of, depending on what we need for balance. Glucose, we most definitely don't want to get rid of. So the things that are getting created in filtration is a mix of good stuff you want to keep, stuff you want to get rid of, stuff you're not even sure, you got to adjust. So the other thing about filtration is this is about 10% of incoming blood becomes the filtrate. So let's do some math here. If 10%, what is, if I'm looking at, again, let's add across all of the nephrons in the kidneys, what is the blood flow coming in?
One little 1.5.
Yeah, so let's say it's about 1.25 liters per minute. So how much filtrate is being formed? This is the flow coming in.
0.125.
So this is going to be about 0.125 liters per minute filtrate is being formed. Right, so if we do the math here, if you do the math, 0.152 liters per minute times 60 minutes per hour times 24 hours per day. I'm gonna get my calculator. I'm gonna do 0.125, enter 60 times, 24 times. This is 180 liters per day. All right, 180 liters, that is, that's like 50 gallons or something, right? So this is obviously not your urine, right? This is not your urine. You don't pee out 50 gallons of fluid every day. This is going to have to be mostly reabsorbed back into your body. You're going to have to bring back almost all, like, 99% of the water. You're going to have to bring back all of the glucose. You're going to have to bring back the salts and stuff that you want to keep in your body. So this first part of the filtration is just the first part. The next part is going to be bringing back the stuff we want to keep. So we're going to collect all of this stuff. This is called the Bowman's capsule. You basically have this tubule. We're going to call this the renal tubule. This is going to have the different parts, the proximal convoluted tubule, the descending limb of the loop of Henle, the ascending limb of the loop of Henle, the proximal convoluted tubule, and going into the collecting ducts. There's going to be lots of parts to this, but for right now, we're going to stick to these overarching, the overview, and then we'll go into the details. All right, so if you remember what is the hepatic portal system? I'm going off, what was the hepatic portal system?
2 capillary beds.
It was 2 capillary beds. In that case, we had a capillary bed in the digestive organs and then a second capillary bed in the liver. This is going to be another portal system. This glomerulus, which is capillary beds, the draining is like, the efferent arterial. Normally capillary beds don't drain into an arterial. Normally capillary beds drain into venules. So this efferent arterial is actually leading into a second capillary bed, what we call the peritubular capillaries. So So this here, this is what we call my peritubular capillaries. As opposed to the glomerulus, which was my first capillary bed. So this was my first capillary bed here at the glomerulus. And then peritubular capillaries here. This is going to be my second capillary bed. Whoops, trying to. So capillary bed 1, capillary bed 2. Peritubular capillaries, this is where we are going to recover the stuff we need to reabsorb. So part 1, I said, was filtration, where you are creating this filtrate. The next part is you're going to have to bring back the stuff you want to keep in your body. So this is going to, part 2 is going to be what we call tubular reabsorption. So basically, almost all of the water, the nutrients, etc. So anything that's in that filtrate that you want to keep in your body, you have to move from the tubule back into your bloodstream. So again, like I said, we're going to bring in back 99% of the water. We're going to bring back all of the nutrients like the glucose. You know, things like salt, it depends on your body's needs. Maybe you'll pull it back, maybe you won't. Part 3, if there is still, so sometimes there's stuff you need to get rid of. Let's say for pH balance, you need to get rid of some H pluses, or maybe you have too much salt and we need to get rid of more sodium, or, you know, there's stuff like that. If there's stuff that's in the body that you want to get rid of, you can actually move it actively from the bloodstream into the tubules, because anything that makes it out the final bottom is going to actually be your urine. So this part 3, though, this is what we call tubular secretion. Tubular secretion is if there is stuff that you want to get rid of, like urea, or could be ions or whatever. Anything that's in your blood that you want to leave your body, you want to excrete, you can move into the tubule where it will ultimately just become part of your urine. So here are the 3 main processes that are going on that we're going to look at in more detail then. Again, filtration. The idea of filtration, you've got the glomerulus, super leaky capillaries, creating this filtrate, again, 180 liters per day. So, and it includes way more stuff that then you want to get rid of because it's pretty indiscriminate. It lets out nutrients, glucose and stuff, as well as wastes. So part 2, tubular reabsorption, you're gonna reabsorb the stuff you want to keep. Again, because you have this peritubular capillaries where we're gonna reabsorb stuff that's in the tubule that we want to keep in our body, move it back into the capillary. The last part here, we can have an active moving things out of the blood into the tubule if you want to actually excrete things out of your body. So are there any questions about these three main processes? We're going to look at each of these in turn. We're going to start with filtration, and we're going to talk about kind of what drives filtration. This is where we're going to end up talking about the renin-angiotensin mechanism, right? Because filtration is ultimately going to depend on the blood pressure. If you don't have adequate blood pressure, you're not going to be actually having the filtrate forming. That's why the kidneys are so, care so much about blood pressure. If you don't have adequate blood pressure, filtration stops. So we're going to talk about how filtration is controlled. Then we're going to get into the details of this tubular secretion and tubular reabsorption. To do that, we're going to have to get into the more convoluted nature of the tubules. We're going to get into the PCT and the DCT and the loop of Henle and place in the different properties. Parts of the tube reabsorb, parts of the tube pump, parts of the tube are impermeable to water, parts of the tube are permeable to water. So we're going to have to look at some of the details. We're not going to get into, if you want, you can get into deeper and deeper and deeper details, but we're going to get into at least kind of the first level of detail, so you've got a sense of the complexity of the nephron. Okay, so let's talk about glomerular filtration. So again, you've got this afferent arteriole coming in, these leaky capillaries that are the glomerulus. Again, these are fenestrated capillaries, so they got little holes, little pores. Where is the efferent arteriole heading to after the glomerulus?
Second bed of capillaries.
So this is heading off to the peritubular.
Peritubular.
Right, so this, again, and we're going to follow that later. When we get to the reabsorption and secretion, we're going to care about that. But for right now, we're keeping our focus on the very beginning of the process, the filtration. And again, like I said, the tubule kind of starts here, it's like a baseball mitt kind of grabbing a ball. We call this the Bowman's capsule. The cells of the Bowman's capsule actually kind of grab around the capillaries to help create this, what we call a filtration membrane. Whoops. It's actually a mix of fenestrated capillaries and then these cells, which we call podocytes. That make these little filtration slits. They're also called slit pores. So between the pores of the fenestrated capillary and these filtration slits from these little cells that are actually from the tubule itself that are kind of glomming around the capillary. That's going to create this filtration membrane, which, if it's functioning properly, is going to allow water and small solutes to go through. So again, water and small solutes. Basically 3 microns. Anything smaller than this can go through. As you get into larger, it gets a little more complicated because charge comes into it as well. But basically, we can say by the time you get to 7 to 9 microns, everything is blocked. Things to remember. So no cells, no plasma proteins. Right, so cells and plasma proteins stay in the bloodstream. If those are starting to get out there, there's a problem with this filtration membrane. And now what we want to talk about is what actually drives the filtration. And like I mentioned, it's going to be particularly that blood pressure, 55 millimeters of mercury of blood pressure pushing in here, which is causing the fluid to leak out. So we're going to look at this in a little more detail now. So we talked about 55 millimeters of mercury coming in, fluid. So we're going to talk about NFP, the net filtration pressure. Hold on, I'm getting sloppy. Let me get less sloppy. So net filtration pressure, that is what's ultimately driving the filtration. And it's going to have the main driver, like I said, is this glomerular hydrostatic pressure. Which I said is about usually 55 millimeters of mercury. What kind of things are going to fight it?
Osmotic pressure.
Absolutely. Right? As more and more water leaves and we still have those plasma proteins and stuff that are staying in the blood, there's going to be more and more of an osmotic pressure pulling back into the bloodstream. Kind of the same thing we saw in the continuous capillary beds, right? So the osmotic pressure ends up being pretty big, like around 30 millimeters of mercury. And then you also just get the back pressure. The more you're kind of shoving water into this limited space, you get kind of a back pressure building up. So we call the capsular pressure, hydrostatic pressure. This is basically kind of the back pressure. And this is somewhere around 15 millimeters of mercury. So if we look at all of these together, the NFP, the net filtration pressure it's about 10 millimeters of mercury. So this is what is ultimately driving this. This is why your kidneys really care about keeping your blood pressure high enough, because if this is not adequate, you're not going to have your kidneys working. In fact, if your blood pressure drops too far, what I have like some, what is it? La 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 la, regulation. Here it is. Yeah, so I guess this makes sense. Like if your mean arterial pressure drops below 45, which is basically this here, you're in your total renal failure, right? So you have lots of ways. We're going to talk a little more. You have ways to adjust this net filtration pressure over a wide range of blood pressures. So, you can kind of So like if your blood pressure is pretty low or pretty high, we're going to talk about different ways that the system has to adjust this net filtration pressure to make sure that it's in the adequate range. But if your blood pressure gets way too high, you might be driving it too hard. Or if your blood pressure gets really low, that's going to affect the ability of your kidneys to be functioning properly because you're not going to be making adequate filtrate. So again, having low blood pressure is going to affect your kidneys. So net filtration pressure is driving what we call the glomerular filtration rate. So you should know this GFR. Right, this is like driven by the net filtration pressure. And we've just mentioned this already. This is around, usually 10% of the incoming flow. So this is going to be, 20 to 25% of that 5 liters per minute. So it's around 100 to like 125 milliliters per minute. This is a typical glomerular, and this is across all the nephrons in both kidneys. Right, so I'm going to be like drawing picture of the nephron and saying, oh, here we got like 125 mils per minute or something, but that's like if you add all the nephrons together. This is something that is, clinically people check to make sure your kidneys are functioning properly. There's a few different ways you can try to assess this glomerular filtration rate. You can look at things that are being produced in the body that are being excreted and seeing kind of how quickly they're showing up in your urine. Again, if we go back to this picture here, like if there's this kind of an amount of stuff in the blood that's becoming filtrate and then is getting like going to show up in the urine. So things that are like creatinine, which is a byproduct of muscle metabolism. You can look at how much of that is showing up in the urine, and it's going to kind of give you a sense of how much filtrate is being formed per minute. If you see like how fast is it showing up in your urine. If you want to get a more accurate readout of glomerular filtration rate, there's this actually cool thing where there's this sugar called inulin. If you put inulin, it gets here, and this is not absorbed or secreted. So it won't get absorbed or secreted, which means any of the inulin that is leaving the capillaries and becoming filtrate is going to end up becoming urine, since it is not reabsorbed or secreted. So you just look at the rate that inulin is showing up in the urine that's forming, and that gives you a readout on the glomerular filtration rate. So you can actually get a measure of glomerular filtration rate by using this inulin test, which is kind of cool. So GFR, glomerular filtration rate. Now what we're going to do is shift into the bigger picture. There's the glomerulus. Here's our Bowman's capsule. Here's our filtrate that's forming. What we're going to be doing as we follow this filtrate and its journey from being filtrate to becoming urine, we're going to look at two different qualities of the filtrate. We're going to look at both how much is still there, and we're also going to be following osmolarity. Like, what's the osmolarity of the filtrate? Because that's actually going to be really interesting and useful in understanding this process. So at each stage of the game here, we're going to look. So if we look at the very beginning, how much filtrate is being formed? We just mentioned it, the glomerular filtration rate.
$125 milliliters per minute.
Exactly. In order to make the math easier for this part of the lecture, I'm going to do the 100 one. So about 100 mils per minute. If we look across all the kidneys, and like I said, this is over 150 liters per day. So obviously this is mostly going to be reabsorbed before we're done with all of the tubule. In terms of osmolarity, both water and solutes are leaving kind of in relatively equal proportion. So which means, what's the osmolarity going to be as we go here?
Be the same.
It's going to be the same, which is what?
Bruce.
Right, 300 milliosmolar. That should sound familiar.
Of course,
Right? It's the same, it's the osmolarity of everything else in your body. So this is where we're going to start. And then we're going to be going into what we call the PCT, the proximal convoluted tubule. And then we're going to go down into the loop of Henle, descending limb, the ascending limb. We're going to go up into the distal convoluted tubule. Ultimately going to go into the collecting duct. We're going to be going into all these different parts. We're going to talk about all these processes. By the very end, you'll have urine, but there's going to be lots of steps in between. The nephron. All right. So we have our nephron here, this big kidney tubule. It's got all these different sections. And we have talked about this first part, the Bowman's capsule and filtration. We've talked about that in depth, and that's leading us to this kind of entrance to the renal tubule here. We've got about 100 mils per minute coming in, and I said it's about, it's isoosmotic with your normal body fluids because you're losing both solute and water during filtration. So the next big section is what we call the PCT, or proximal convoluted tubule. So the proximal convoluted tubule, this is mainly a place for reabsorption. So this is about like 65% of filters. I keep making that capital. I don't want the capital. Let's forget it. So the PCT, so obviously to make this picture make more sense, I should put the peritubular capillaries. Obviously the peritubular capillaries are all over the place here. So this is where we take in the stuff we want to keep that's still in the tubule and moving it into the bloodstream. So this is reabsorption, taking stuff that is in the tubule and bringing it back into the body. And like I mentioned, about 65% of the filtrate is reabsorbed here, which means by the time we get to the entrance or to the end of this process, like when we get here, we're down to about 35 mils per minute. I mean, again, let me try to write a little neater. And because we're reabsorbing we're reabsorbing both solute and water, we're still about 300 milliosmolar. So that is the PCT. There are a lot of details about how it does what it does that you don't have to know in detail. Some of what it is doing, you already know from transepithelial transport. Remember how we talked about transepithelial transport with absorbing glucose from these intestines? It's the same like here. When you're pulling the glucose back from the tubule into the bloodstream, it's the same basic idea, right? It's going to be carriers and secondary active transport and symports and things like that. And in fact, when we talk about diabetes a little later, like why, there's a limit to how fast you can reabsorb sugar from, because like we talked, nutrients like glucose ends up in the filtrate. And obviously, in general, you want to pull all the glucose back into the bloodstream. You don't want to pee out glucose. Glucose is like gold in terms of like nutrient energy. But that process of reabsorbing the glucose involves carriers. If you remember, the glucose carrier was an important part of transepithelial transport. And what do we know about carriers? How are carriers different just from like pores and stuff?
They use ATP.
There's a limit to how much.
No.
Yes, Stephen's got it. Say that again, Stephen?
Well, there's a limit to how much they can go across the membrane because it pops up.
They're rate limited. We talked about facilitated diffusion where there's a limit to how fast things can move across if you're using carrier, which means there is I think that's coming. There's a limit to how fast you can pull the glucose back into the bloodstream from the PCT. So like in diabetes, where you have way too much sugar in your blood, which means you have really high levels of sugar in the filtrate, means you get past the PCT before you've reabsorbed all of the glucose, which means some of the glucose ends up making it into your urine. So that's like part of one of the main symptoms of diabetes mellitus is there is sugar, there's glucose in your urine. You know, that glucose in your urine is because there's a limit to how fast you can reabsorb the glucose here because of the processes that we got to meet in the very beginning of the class. So you can kind of see how it's all kind of connecting. Okie dokie. The next part here is the loop of Henle. And there's a descending limb and there's an ascending limb. The properties of these two parts of the loop of Henle are super different. And I'm going to describe first their basic properties, but then I'm going to talk about how they work together to create this really important gradient as you go down into the kidneys. So let me just tell you about the properties. Descending limb. Permeable to water. So water can cross in and out. Not permeable to salt, or to solutes, I should say. So descending limb, permeable to water, but not permeable to solute. And again, this is all going to make sense in a few moments. The ascending limb is very different, impermeable to water. So impermeable, not permeable to water, actively pumps sodium out of tube. So it's actively pumping sodium out of the tube. That's driven by ATP. And for this also to make sense, we have to kind of bring it this idea, like a pump has a certain amount of, whoops, back. Think about, actually, let's change, let's say there's a fountain. Let's say you've got like a fish fountain and there's a water in here and there's some pump that takes the water and goes up and then the water goes and then the water falls back down. Then the pump pushes the water back up and it goes against gravity, but then gravity pulls it back down. So this should feel kind of intuitive. That's like if you had like some cool in your backyard, you had like a pump pushing a water up through a statue of a fish, and it looks like the fish is spitting up into the sky. How high the fountain goes depends on how powerful the pump is, right? Because you've always got gravity pushing back. So the stronger the pump, the higher the water is going to go before it starts falling back. When I'm in my loop of Henle, pumping sodium out of the ascending limb of the loop of Henle, I'm using ATP to drive this. I'm pumping out. This is active pumping using ATP. The amount of strength that this pump has, because remember, the more sodium I pump out here, I'm going to have an osmotic gradient that wants to make it want to move back in, right? As soon as I have more sodium out here than in here, there's a, not osmotic, diffusion gradient. There's as soon as I start pumping sodium out, sodium wants to come back in. So this pump is able to maintain a difference of up to 200 milliosmolar between the inside and the outside. Right, so if this pump is going full bore, it can be 200 milliosmolar higher outside than inside, but at that point, the drive to come back in overwhelms the strength of the pump to push it out. So if it is 300 inside, it can pump it out. It can be 500 outside and 300 inside, but I can't make it any more. If it's 500 outside, I can't make it even lower inside because there's too much of a force trying to come back in. So the highest difference you can have between the inside and the inside can be 200 milliosmolar lower than the outside. So what I'm going to show you now is pretty cool. So you've got to think about this loop of Henle. Again, the descending limb, permeable to water, not permeable to solute. The ascending limb, not permeable to water and actively pumping sodium. And what I'm going to do now, I'm going to share some, these are actually PowerPoint images from the textbook I used to use. The woman who wrote the Sherwood book, Laurel A. Sherwood, this is more of her bailiwick. So she actually has some better images than the Silverthorne. So I'll put this PowerPoint up on the Canvas as well. But what you need to think about here, again, I need to get my little pointer. Let's see. Again, we're in the kidneys. Here's the kidney. And again, the kidneys have all of these nephrons in here. That's supposed to be a PCT. This is supposed to be the loop of Henle, the descending limb, the ascending limb of the loop of Henle. So there are different populations of nephrons. The ones we're going to worry right now, they're called juxtamedullary nephrons. These are the ones that send their loop of Henle way down deep into what we call the renal medulla, the deep part of the kidney here. So there's this cortical part, the outside part of the kidney, but then these loops of Henle are going down deep into kind of more of the core of the kidney, what we call the medulla. So, and again, this part permeable to water, not solutes, this part pumping sodium out. And what's going to happen is pretty trippy. Ah! Well, hold on, I went too far. There it is. Okay. So this is going to be what's going on. This here is the initial scene. This is, imagine, so this is not what it looks like in your kidney, but imagine everything in the kidney is at 300 milliosmolar. It's 300 milliosmolar inside and outside of the loop. And then we think about the ascending limb is pumping sodium out. So it can pump sodium out till it's 200 higher outside than inside. But now as it becomes more or higher osmolarity outside on the descending limb, we're going to have osmosis. The water inside the tube is going to leave because of osmosis. So because the two sides are different, one side is pumping salt out into the outside. The other side is going to lose water because of osmosis. And then as that happens, you know, there's flow. And now we can kind of, oh, she doesn't. So this keeps going and going. Oh, dagnabbit. If you keep going and going, okay, I thought this had it. I need to go into another, hold on, sorry about this. La, la, la. Here it is. All right, so it's kind of where we were. We move this forward in time. You keep going and going. It's gonna keep happening until it kind of reaches an equilibrium. We're down at the bottom of the loop of Henle. It's about 1,200 milliosmolar. You know, near the top, it's going to still be 300, but because of this pumping and osmosis and the flow through the loop, by the time this whole thing is done, you've got this osmotic gradient inside the, hold on, let me see, slideshow from current slide. You know, this is the cortex. This is where kind of the glomerulus is. And then we have that whole loop of Henle going down. That loop of Henle is creating this osmotic gradient, where as you get deeper and deeper into the kidney, it becomes more and more salty, so to speak, higher and higher. You have 4 times the osmolarity down in the deep part of the kidney compared to the cortex, to this outer part. So that's going to be critical when we look at how the kidney is going to pull the water back into the body. This really high osmolarity down here in the deep parts of the kidney are going to be used to pull water back into the body by osmosis. So that's important. Boo, 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 boo. So again, this is the reality more of what the nephron is looking like. We've got the glomerulus. Here's that PCT where we have all that reabsorption happening, and you can see the peritubular capillaries all around it where the water and nutrients and stuff are getting pulled back into the body. Here we have the loop of Henle coming down, which is helping create this gradient. Then we're going to have the DCT, and then this collecting duct, which is going to be important too. The collecting duct which a lot of nephron, you can have more than one nephron go into one collecting duct. But the important thing about the collecting duct is it's going down into through that high osmolarity area. You know, to get out of the kidney, it has to go through the medulla. So as we go down through here, we're going through that super salty area. Again, down here, I said is more like 1200 milliosmolar, 4 times the osmolarity of up here. So as we travel down through here, it's going to be super high osmolarity outside, which gives us the opportunity to pull water back into the body. So keep that in mind as we finish up our discussion right now of the nephron and the collecting duct. Okay. Glomerulus, Bowman's capsule, PCT, descending, ascending limb of the loop of Henle. So like I said, PCT, again, we are reabsorb about 60% of filtrate. So by the time we get here, again, up here, we started at 100 mils per minute. By the time we're here, we're about 35 mils per minute. 300 milliosmolar. So now we've added in this other factor now, though, that, you know, just in the kidney, it's about 300 milliosmolar outside. When you get down here, it's about 1200 milliosmolar because of the property of that loop of Henle. So now here in this descending limb of the loop of Henle, which we said is permeable to water. If it's permeable to water and the filtrate that's coming down is 300 milliosmolar and it's 1200 milliosmolar outside, what's going to happen?
Water will go out.
Water's going to totally go out. So we have osmosis, we're losing water. By the time we get to the bottom of the loop of Henle, we've lost like another 15, 20% of the original volume. So by the time we're down here, we're down to maybe 15, or it's actually more like, I think it's like 20, like about 20 mils per minute. Because we have just lost a whole bunch more of the water due to osmosis. You know, because water is leaving, but no salt, you know, it was not permeable to solute. We have about 1200 milliosmolar. It basically equilibrates. Water leaves until it's the same inside and outside. But then when we go up the ascending limb, we said the ascending limb is pumping out sodium. So by the time we get to the top here, what is the inside going to be? If I can be 200 less than the outside with this pump,
Be 1,000.
No, remember what?
Or 100? It was,
Right, exactly. We're down to like, so it's actually much more dilute than normal body fluids. You know, down here, it can get down to 1,000, but as you go up, we have this gradient which goes from 300 to 1,200 as we go from what we call, this is the cortex, the kind of outer part, the medulla, the inner part. So by the time we get to the top here, and because we're not losing water, this is still maybe about 20 mils per minute. So we have much dilute, but still quite a bit of, 20 mils per minute is still a lot of fluid. This is going to finally go into this collecting duct, which we need to talk about as the last part of this. So this is going to leave the kidney. So this is going to be to the ureter here. Right. Again, if you've been in anatomy, the collecting ducts all feed into those little renal papillae, into the minor calyces, into the greater calyces, into the renal pelvis, into the ureter. So at the end of the collecting duct, it is urine. It's what leaves your body. But the collecting duct is the last opportunity to adjust things. Oh, and I forgot, this is the DCT here, the distal convoluted tubule. The distal convoluted tubule, it has more secretion as well as some absorption as well. But it's just more places for things to either get into the tubule from the blood or leave the blood into the tubule. But the DCT does not do a lot of dramatic reabsorption. So we have about 100 mils per, about 20 mils per minute entering in the DCT. There's about 20 mils per minute entering into the collecting duct here, which means if you did not reabsorb any more of the water, you would have a large volume of pee. So we can pull more water back into the body here. Typically, you end up reabsorbing almost like 99% of the original volume of the filtrate. To pull water back into the body, we are going to have these little aquaporins. So they move H2O across the membrane. They're called aquaporins. If the aquaporins are open, you're going to be pulling a lot of water back into the body because it's 1,200 milliosmolar outside, right? And the stuff coming in is 100 milliosmolar as it's kind of entering in. So if it's 100 milliosmolar inside and 1,200 milliosmolar outside, the water is going to go back into the body. The aquaporins are under the control of the hormone you've already got to meet. What hormone is in control of aquaporins?
ADH.
Antidiuretic.
Yep, this is regulated by ADH. So ADH, which is a hormone that's coming from the pituitary gland, we'll talk about it in more detail. But if you have lots of ADH, you open up more of the aquaporins, you pull more of the urine or the water back in the body. That means you don't pee as much, right? Instead of having the water leave, the water is getting pulled back into your body. Alcohol inhibits the release of ADH. If I inhibited the release of ADH, what would that do?
You would lose more water.
More.
If I don't have these aquaporins open, that means I'm just going to have much larger volumes of very dilute urine coming out because I'm not going to be pulling the water back into the body. Right? If I have 100 milliosmolar stuff coming through, but the walls are all sealed, then it just makes it all the way through. If I do have ADH and the aquaporins are open, then osmosis, the water gets sucked back into the body. So that's one of the big things happening in the collecting duct. The one other thing happening in the collecting duct is a hormone which you've also met when we talked about the renin-angiotensin. Aldosterone can turn on additional sodium reclamation here. So this is getting really messy. So reclaim sodium if aldosterone present. So there's two hormones. This is getting so messy. So collecting duct, there's two major hormones at work here, ADH and aldosterone. Again, you think about, here's the kidney. Like I said, it's like 300 milliosmolar up here, but like 1200 milliosmolar when you get down deep. There's that gradient. And the collecting ducts are basically draining, going down, and ultimately going to leave the body. So here's a collecting duct. Which is, getting, here's my nephrons are feeding into this. So antidiuretic hormone is going to open up water channels. Water channels mean H2O is going to come back into the body because, again, the filtrate entering here is only like 100 milliosmolar and it's 1200 milliosmolar outside. So the water gets sucked back into your body. Aldosterone is going to turn on sodium pumps that reclaim sodium back into the body. These can be independent. You can turn one or the other on or off, either open or close the aquaporins. Turn on or off the sodium pumps. But if you have both working together, that's gonna be the most, if you're really trying to hold water in your body, you do both of these, which we saw in the renin-angiotensin mechanism, right? We turn down aldosterone, which pulls even more sodium back into the body, and we turn on ADH, which opens the aquaporins. So that's even going to be even more of a gradient to reclaim water. If we're pumping sodium as well as got the intrinsic huge gradient, that's going to be the maximum ability to keep water in the body. So these can be independent, sodium balance versus water balance, but if you're really trying to keep water in the body, you can turn them both on. So Other questions about that? Okay. So again, nephron. Kind of the PCT, which is reabsorbing. Loop of Henle, which creates and maintains that osmotic gradient, which is essential for the kidney to function, as well as more reabsorption. The DCT, another thing the DCT does, which is going to create what's called the juxtaglomerular apparatus, so there's this little junction. I'm not going to go into detail because of time right now, but basically, in a nutshell, there are special cells in the arterioles, and there are special cells in the DCT that work together to become what's called the juxtaglomerular apparatus, which you should know the name of this thing. So juxta means near, glomerular meaning, so near the glomerulus apparatus. So these are specialized cells within the arteriole and the tubule. And they monitor both blood pressure, right? Just stretch of the arteriole is going to give you a measure of blood pressure, right? We've talked about how stretch receptors can detect blood pressure. And also, they also monitor filtrate composition. Right, the DCT can monitor like the osmolarity, like how much stuff is dissolved, what's going on inside the tubule. So both of these are part of this process to make sure the glomerular filtration rate stays intact. If the blood pressure is dropping, or if the filtrate composition looks off, again, we're not going to go into the detail. There's a variety of things this thing can do, but what's one of the main things that is going to be released here if your blood pressure is dropping to keep the glomerular filtration rate up?
Renin.
Exactly. So that's why I wanted to make sure that I brought this in. This releases renin. In particular, what would cause it to release renin?
Detection of low blood pressure.
Exactly. If it detects a drop in blood pressure, then we're going to release renin. Just as a review for your exam on Tuesday, what happens next once it releases renin?
Does that convert angiotensinogen into angiotensin 1?
Exactly. So first step, angiotensinogen becomes angiotensin 1. What happens next?
It gets converted into angiotensin 2.
Yeah, angiotensin 1 becomes angiotensin 2 through the action of angiotensin converting enzyme, ACE. Like I said, one of the major drugs for high blood pressure are ACE inhibitors, things that are going to stop this process at this point. But assuming you're not on an ACE inhibitor, what happens next to bring your blood pressure back up?
Vasoconstriction.
So one, angiotensin 2 is a potent vasoconstrictor. Vasoconstriction increases resistance, brings your blood pressure up. And that's one piece. What else?
ADH and aldosterone are released.
So ADH is released from the pituitary gland, which we've just been talking about. What are the what are the different things ADH does to keep your blood pressure up?
Reabsorbs water.
So one is it's keeping the water, keeping your blood volume up. We just saw it's about keeping water in your body. And we said keeping blood volume up is an important way of keeping your blood pressure up. What else does ADH do?
And it's a potent vasoconstrictor.
It's a vasoconstrictor as well, which is going to do upping blood pressure by increasing resistance. We also talked about how it talked to the hypothalamus and increased thirst. So you brought more water in your body to increase your blood volume. And then there's aldosterone. What is aldosterone doing to help with blood pressure?
Conserves sodium.
What's that?
It conserves sodium.
So it's the one that tries to pull sodium back in. And by pulling more sodium in, that's going to increase the amount of water retention as well to keep your blood volume up. Right? So all of those things, that's important. I promise you there will be questions on your exam where you need to understand the renin-angiotensin mechanism because it's a critical part of your blood pressure control. So make sure that that all makes sense, everything we just talked about. And again, it's being initiated by this juxtaglomerular apparatus here. So any questions about that? All right, let me take a look to see if there's anything else that's critical that we didn't talk about. Let me go back, share screen. Again, just kind of to review everything. The kidneys are complicated. There's a lot going on. You should know it at the level that we've been talking about it. When you read in your book, it's going to talk even more detail about things. Don't get caught up in the nitty-gritty details. Think about the bigger picture that we've addressed in the class. Again, you should definitely know the main idea of kidneys getting a quarter of your cardiac output here, processing, doing all those things, whatever finally leaves goes out the ureter. The idea of having a million nephrons all working in parallel, doing filtration, tubular reabsorption, tubular secretion. The idea that there is this gradient, it's normal 300 milliosmolar in the cortex, but you get down to like 1200 milliosmolar down in the medulla due to the activity of those deep loops of Henle. Oh, here, internal sphincter. Again, the one that is smooth muscle, this one is just going to relax based on stretch of your walls of your bladder. It's going to be a spinal reflex integrated in the spinal cord. When that one relaxes, you get more pressure down on the external sphincter. That's when you have the urge to urinate. Again, external sphincter, which is actually kind of part of your pelvic floor muscles, that's skeletal muscle. So then you can choose, is it time to pee or not? You can relax it. And if you do, you pee. And again, when we get to the male, we're going to see there's a lot more going on. This little space between the internal and external urethral sphincters are where we're going to mix all the different components of the semen in the, we'll call the emission phase of ejaculation before the expulsion phase, where you actually have the white goo come out. Again, this idea, you have the initial capillary bed, which is the glomerulus, where you're creating the filtrate, but then that feeds into a second capillary bed, the peritubular capillaries, where we do the reabsorption and secretion. Because the filtrate, you're making, again, 180 liters a day, including all of your good nutrients and stuff. So you're going to be reclaiming almost all the water, all the good stuff before you finally get to the very end. Again, collecting duct's the final step. And then at the end of the collecting duct, you're heading out the body, and that's going to be your actual pee. Well, this is a cool image of a glomerulus. This is just kind of showing this the more schematic. Again, like I said, filtration, reabsorption, secretion, and then ultimately leaving the body. This is kind of cool. This is showing, like I said, the podocytes, the little cells that glom onto the capillary, make these little slits to make that filtration membrane. Again, this is a cool photomicrograph showing those little slips there. Again, this is talking about net filtration pressure. 55 millimeters of mercury is the hydrostatic pressure of your blood coming in, but you've got about 30 millimeters of mercury osmotic pressure pushing back against there. About 15 millimeters of mercury of the just the capsular hydrostatic, basically the back pressure, which means net filtration pressure is about 10 overall, 10 millimeters of mercury. And that's what's driving filtration. Again, if your overall blood pressure drops too low, so you don't have this original one, then your filtration stops and you're going to be in renal failure. Oh, this is showing the juxtaglomerular apparatus, kind of specialized cells in the tubule, specialized cells in the arteriole that are detecting your blood pressure, detecting the content of the filtrate, and making a decision on whether to release renin or not into your body, and do a whole big cascade of the renin-angiotensin mechanism. You know, here we're talking about all this transepithelial transport. Don't get too worried about this. Yeah, so this is where I'm saying don't get too concerned about details. All right, this is just showing the arterioles coming in into all the little glomeruli. It's just pretty. All right. Let's see. So are there any questions about any of that?
But even like a more generalized question, like things that affect blood pressure, like end diastolic volume would be an appropriate answer, or like you're just not even going to write the question to be like that tricky. I'm just trying to figure it out to kind of help with my studying techniques.
No, I mean, I think the fact that you're asking that question means that you are understanding all these relationships well.
Mm-hmm.
Because ultimately, right, I mean, part of the reason, here I can go. The beta blockers. Why do people take beta blockers for high blood pressure? One of the things that beta blockers do is reduce contractility of the heart muscle. Reduce cardiac muscle contractility, contractile strength. And that is going to mean that you are going to increase end systolic volume because it's not squeezing as hard. So we're going to have more blood left still after we're done with end systole. And stroke volume was end diastolic volume minus end systolic volume. So if this is going up, stroke volume is going down just because of the math. And then we know that stroke volume times heart rate is cardiac output. So if stroke volume is going down, cardiac output's going down. And then we know blood pressure is cardiac output times resistance. So if cardiac output's going down, keeping blood pressure down. So actually, to understand one of the reasons beta blockers are useful, you actually do have to think exactly like you're saying.
Okay.
Like if I have a question about beta blockers, you'd have to understand both they're affecting stroke volume, which affects blood pressure.
Mm-hmm.
They also affect heart rate though too, right?
Yeah, so heart rate, which is also going to be bringing, so both the stroke volume and heart rate come down or stay down, which keeps the cardiac output down, which keeps the blood pressure down. Yeah, no, exactly. So, yeah, no, so, yeah.
With the loop of Henle, like you were saying that as you get deeper into the kidney, the osmolarity goes through the roof.
Yeah.
I'm not really understanding why, because in that descending limb, water is coming out, and then on the ascending limb, it's pumping solutes. It's pumping the sodium back in. So like, wouldn't the two balance each other out? I don't know why I don't know if I'm phrasing it right, but
Because there is a flow. Here, I'll show the thing in the Laurel Sherwood. Let me find it. Here it is. Yeah, this is it. Okay, I'm going to share this with you. It has to do with the fact that things aren't static. The fluid is moving forward through the loop of Henle. So here, let me see, I'll do the slideshow from current slide. And let me get a pointer. Let's change the color. All right. So again, this initial scene, this is artificial. This isn't real. But let's just assume we have something that's completely homogeneous. All right. In which case it's 300 milliosmolar in all the extratubular, and it's 300 milliosmolar in the filtrate that's moving through the tube. But then it's also important to remember that the fluid is moving down here and up here. So moment to moment, it's continuing to flow. So then she says, all right, let's go over here. As we start, we have to go over here. In the first moment here, number one, we have this is the ascending limb pumping out. So it can pump to 200 milliosmolar difference. So it was, remember it was 300 in here. It was 300 everywhere when we started. Now it's 200 in here. and it's 400 out here because we just pushed all that sodium out. And as soon as it's 400 out here, water is going to leave the descending limb because of osmosis, because this is permeable water. So now things flow. Fresh 300 mils comes down from the top. This 400 mils is now starting to go up the other side. Once it's going up the other side, we now have that 400 here is now 300 in here and 500 out here. And this is now equilibrating the 500 in the descending limb. So now it's 500 here. And now, keeps flowing. Now we have 500 starting down here. And now when it's 500 down there, now it's equilibrates as we pump out the sodium.
Oh, okay.
And now this is 600, and this becomes 600 because this is osmosis. And now that 600 flows up into there. And when that 600 flows up into there, now all of a sudden we have, ultimately you end up getting where it finally stabilizes is when 300 is coming in from the top constantly, 1200 at the bottom. So this is kind of just where it equilibrates.
Okay. I think I get. Are we recording this? This is a good explanation.
Actually, I am recording it. Yeah.
No. Yeah. It makes more sense now. It's thinking about the flow.
Yeah. You have to. And on your exam, I'm not going to hold you accountable to the details of this. You should know that the properties of the loop of Henle are responsible for creating and maintaining that gradient, but don't worry too much about making sure you can reproduce this explanation. This
creates that gradient.
It creates and maintains it. And I think it's totally cool how it does it. Again, in the Sherwood book, she spends more time going into the details. I don't think Silverthorne goes into the details as much. But I think it's really kind of cool. But yeah, that's what's happening there.
Okay. Yeah, I think I get it now.
And I just shared a video that was in my anatomy class from last semester that Tina had shared with the class explaining that flow.
Oh, thank you.
Yeah, no problem.
Cool. Let me, so you put it in the chat.
Yeah.
I wonder if let me try to save that so then I can just post it to everybody.
Why running on the treadmill 7 days a week doesn't work for you when you're trying to lose weight? Because
Right, these ads. But yeah, so Emily, I'll put that up on the website. So
okay,
on the Canvas module, so people can see that. But don't get too caught up in that. I don't want you to spend a lot of time learning the details of that as opposed to learning just the fundamentals.
Okay. All right, Dr. Thank you.
Sure. All right. Have a good weekend.
Yep, you too.